Hi, everyone, and welcome to the Heart of Innovation. Dr. John Phillips is off saving those piggies today at Ohio Health, so he is not here with us today. We do have a special guest co-host. We have Douglas Salisbury. He is the chairman of the Global P.A.D. Association's Patient Task Force, and he is going to join me, my sidekick today, since Dr. John Phillips can't make it, and he is going to be helping me to have a very broad discussion with our guest of the day. It is Dr. Rex Teeslink. He's an interventional radiologist, inventor, and entrepreneur, actually retired interventional radiologist, but not retired in any other aspect of his life or career because he is still going strong and trying to improve the treatment for people with peripheral artery disease, and peripheral artery disease being those blocked arteries in mainly the legs that left untreated could lead to heart attack, stroke, as well as amputation. It's a disease more prevalent and deadlier than most cancers, and it doesn't get the attention it deserves. But early diagnosis, early conservative treatment can make the difference in the world in all of these patients. And so we're seeing innovation in this space, just moving at the speed of light. And he is at the forefront of it. We're going to get into what he is doing, what he has done, how he's seen the treatment for peripheral artery disease evolve over the past few decades since he began his career in this space. So we're going to get to all of that in just a moment. But first, I want to check in with Douglas. We always have a moment of inspiration. Dr. John Phillips usually has it for us. Would you mind, Douglas, chiming in with a moment of inspiration?
Good morning, my fellow P.A.D. warriors. Usually this is where Dr. Phillips shares a moment of inspiration with us. So I'm going to share one of mine, and I'm going to piggyback along what Kim says about our light a candle for tomorrow in this coming month. To remember the inspiration of hope, courage, and strength with every step we take every day.
I love it, Douglas. And it's probably music to your ears, right, Dr. Teeslink, to hear a P.A.D. patient himself saying, hey, walking is the best medicine. We got to walk. We got to just take one more step to improve our prognosis.
And that is absolutely true.
Yep, definitely. Thank you, Douglas, for that. And with that, let's bring in Dr. Rex Teeslink. We are live actually at the new Cardiovascular Horizon show in New Orleans, Louisiana. And this is a show, it's a conference for doctors to come together and to talk about what's new, what's next, and collaborations for the future to improve the care for people with peripheral artery disease. And Dr. Teeslink and I met, oh my gosh, quite a few years ago. I think even way back in 2016, when I first started coming to this show. Dr. Teeslink was always that person, always had a big smile on his face, always wanting to help mentor me, answer any questions that I would have, introduce me to some of the who's who of doctors that are treating peripheral artery disease in the most advanced ways. So I just appreciate all of your support from the very beginning.
Well, thank you very much. It's been my pleasure. You know, this is the 25th year for this meeting, and I've had the good fortune of knowing Craig Walker for a long, long time, and I have been a part of this meeting for every year of the 25 that it's been in session.
Wow. And so you started out, would you mind telling people who aren't aware, what is an interventional radiologist? How would you define it? And I would be curious how it's evolved from when you were like, what was it when you first decided to go into it, and how has it evolved since?
Well, I went to undergraduate school and to medical school here in New Orleans at Tulane. And my intent all along was to go into a surgery program. I grew up, I was actually born in South Dakota and grew up in a small community in the Ozark Mountains of Missouri. And of course, cold weather, snow, ice. And I decided that when I had the opportunity to decide where I wanted to go to school, I was going to go somewhere where the sun would shine as many days out of the year as possible. But
That's a good call.
But the point I was going to make is at that point in time, fortunately, I had an externship at Charity, so I got to live in the intern residence course. Charity Hospital had an average of 3,000 patients a day in the hospital itself, and then 25,000 patients in the outpatient facilities. So the amount of opportunity that we had to really get involved with patients, learn the disease. Having the advantage of living in the hospital, I could be there all the time.
Mhm.
And it was just an amazing opportunity. And unfortunately, some of that doesn't exist anymore.
Yeah.
But the point I was going to make is because of the size of the hospital and the limitation of enough personnel, I was able to start doing some of these procedures while I was still in medical school.
Wow.
And you asked what interventional radiology is or was. The only docs that were doing anything peripheral were the interventional radiologists. And it all started initially with interventional radiologists. And then, of course, Dr. Dollard at Oregon was one that really kind of pushed it here. But interestingly enough, the thing that sort of really kind of brought it to a head was Johnny Carson. I don't know how many people know, but Johnny Carson was basically a chain smoker. And he developed a total occlusion of one of his iliac vessels.
No.
And started having claudication. And he ended up having a doc treat that and open that vessel up. Again, an interventional radiologist opened it up, and he talked about that on his show, and people started realizing that maybe there was something that could be done. And the reason we were involved for so long was because interventional cardiology didn't start till 76. And neurointerventional really became an entity in 84. So basically, we were doing the whole body, whether it was roadmaps or interventional procedures. My first catheters came from Sweden. They were called Kifa catheters. They were 6.2 French size. They were light pink. They had about as much torque to them as damp spaghetti.
Oh, no.
And they came on a spool, just like thread does. So you'd have to take the length of catheter that you want from that roll, and then make both ends, and then try to get it to go where you wanted it to go. So the advantage of that is you really, really had to learn technology, because we didn't have all the super fancy technology that's available today. And it's amazing what is available today. So fortunately for me, I kind of got in on the ground floor of this specialty. The reason I got into it is, as I said, I started off in surgery. And when we got to where we were trying to do some blood vessel surgery, radiology didn't know anything about technique. And we had to have radiology involved to be able to get the images that we needed. And of course, we didn't know anything about radiology. So it became apparent that if you're going to operate on blood vessels, you got to have roadmaps first. And so I started looking around to see where I could go to find a place that would allow me to both learn the radiology end of things as well as the sterile technique of things. And that ended up by my going to the University of Virginia for my residency.
Coming up right here on the Heart of Innovation, we're going to hear more of Dr. Teeslink's story and how the treatment for peripheral artery disease has evolved over the past few decades. So stay with us right here on the Heart of Innovation. Don't go away. Hi, everyone, and welcome back to the Heart of Innovation. We are live at the new Cardiovascular Horizons Conference in New Orleans, Louisiana. It's a place where doctors gather every single year. This is the 25th anniversary of Dr. Craig Walker's event. Dr. Craig Walker is the CEO of the Cardiovascular Institute of the South, and he's also the founder and CEO of the new Cardiovascular Horizons Conference. It's been going for 25 years. It's a place where doctors can go to learn about the new tools, the new techniques, and the treatment of vascular diseases. Our specialty, of course, is really peripheral artery disease. The peripheral vascular disease is when you have both the issues with the arteries and the veins. And so today, if you can hear in the background, there's a lot of noise. They're live simulcasting the educational series where doctors are teaching other doctors, and you can kind of hear that in the background of our broadcast here. But Dr. Phillips is not here. Dr. Phillips was actually broadcasting live to another conference over in Germany this week. He was performing a case in Ohio at Ohio Health, and they were literally broadcasting that case where he was saving some piggies clear into teach doctors in Germany some of his tools, some of his techniques. So that was interesting. So he is not here with us. Instead, we are honored to have our guest co-host. We have Douglas Salisbury. He is the chairman of the Global P.A.D. Association's Patient Task Force. And so thank you, Douglas, for joining us. He'll be chiming in with some questions here or there, but I want to turn it back over to Rex Teeslink, who is an amazing interventional radiologist, inventor, and entrepreneur. I've known him since 2016 and coming to this event. And before the break, he was talking about the evolution of peripheral artery disease treatment or peripheral vascular disease treatment and the role of the interventional radiologist. And something that caught my attention was the fact that you said that Johnny Carson, everyone's always looking like who famous has had peripheral vascular disease? Well, Johnny Carson, I don't know how people would forget about him. You mentioned that he had his artery opened up, and I wanted to get into a little more details. Like, what was the timeline? When did this happen? And then how was it opened up? Was it because I'm confused on the timing. I know that in I think overseas, you were mentioning maybe in Sweden, they started opening up arteries in a minimally invasive way somehow. And I want to know the timeline of when it got to the States, because I know that in Oregon, there was a case where Doddard, had a patient that was given to him by a vascular surgeon. It was an 80-something-year-old woman who said, I don't want to have amputation. And so he went to his interventional radiology colleague and said, you guys do a bunch of stuff with wires and catheters. Can you do something with this patient? And I thought that's how it evolved here in the States. But was that before or after Johnny Carson?
That was before, actually. Yeah. Unfortunately, we did not have the balloons were not accessible until the early 70s. So Doddard came up with an idea of serially taking dilators, starting with a smaller dilator, increasing it up to, increased it up to a 10 French, so he could treat the iliac vessel.
So they were basically taking different sized catheters?
Right, and what they were doing is they were basically just squishing the moisture out of the plaque, and they weren't able to do it didn't have the same effect that the balloons did when they came, but it was very effective for at least enough time for the patient to come back earlier if they had a recurrence. But this all started in 1957 with Dr. Seldinger in Scandinavia.
Okay.
And he did the first puncture of the femoral artery with a special needle that he had. Interestingly, it had
a special needle.
Yeah. Well, it was his needle,
Okay.
and the problem with it was it had what we call an obturator. So it was something that went inside the needle. He would stick the groin, and then he'd pull the needle back, and then retract the needle itself, trying to wait till he got blood and then put a guide wire up. But we learned that oftentimes that would stick the back wall too, and that potentially had as I said, the potential of causing some bleeding.
Yeah, perforating the vessel.
Yeah. Well, yeah, because you make a hole in the back wall.
Right.
And anyway, obviously we use needles now that have nothing to obstruct them. You actually want to do a one wall stick and get blood out.
Mm-hmm.
But I'll go back to where we were talking. I was a resident at the University of Virginia, and Dr. Keats, who had become the chairman, I was part of the first group of residents that he recruited. He'd have been on sabbatical over in Scandinavia, and he brought a gentleman that was considered the best angiographer in Sweden at that time by the name of Ivar Inga. He brought him back with him. Unfortunately, after 2 years, there was a problem with his green card, and they told him he had to go back to Norway for 2 years. Then he could come back, and then his family didn't want to do that. So Dr. Keats knew that I was very interested in doing just the vascular end of things. So he allowed me to have all my elective time with Dr. Inga. So when Dr. Inga left, I got to take over basically being responsible for the vascular work at that point in time. And so I took call every night my senior year to be able to get as much experience as possible. Then when I finished my residency, I went to the Medical College of Georgia to be chief of the section of vascular and interventional radiology, and I did that for almost 40 years. But when I got to the Medical College of Georgia, Manuel Villamonte was in Miami, and John's route had got to Duke about 10 months before me. There was nobody in Atlanta for 2 years. And when the first person came, all he was interested in was doing neuro work. So but between the three of us, we had the whole Southeast that we were basically responsible for.
For the vascular
end of things, yes.
Wow.
Yeah. And, fortunately, there were companies that were realizing the potential of what was going to happen down the road and started making devices that were going to allow us to have better opportunities to access the areas we needed to and then start treating them. But it was an interesting time, and fortunately, being in the right place at the right time to kind of get in on the ground floor. I ended up being, if you're the first kid on the block, you kind of get some privileges that maybe you don't get later on.
Right.
And so I kind of had my own little outpatient facility within the hospital. I had all my own. I had my own transportation people, my own scheduling people. We had our own holding area, and we got to handpick all the technical people and nurses that we wanted to work with us.
And coming up right here on the Heart of Innovation, we're going to find out, after choosing his team, what they were able to do with it, how they helped the treatment of peripheral vascular disease evolve over time. So stay with us right here on the Heart of Innovation. Don't go away. Hi, everyone, and welcome back to the Heart of Innovation. Dr. John Phillips is busy saving some piggies. So our friend Douglas Salisbury is here. He's the chairman of the Global P.A.D. Association's Patient Task Force, and he is making sure that we're staying in line here. He might have a question or two, as we go along in the story of Dr. Rex Teeslink and how the treatment of peripheral vascular disease has evolved. Prior to this segment, we had talked about how Johnny Carson, famous comedian, talk show host, actually helped to put interventional radiology on the map in the 1970s. But prior to that, Dr. Teeslink was helping this entire industry evolve. And before the break, you were talking about how you were building your team over in the Southwest. There were three of you, right? Initially doctors that were covering the entire Southwest.
Yes, one in Miami and one at Duke and myself.
Oh my goodness.
Yeah.
So you guys had quite the undertaking.
We did actually, because I was at the medical college and the private community wanted the same procedures done. There was a rule at the medical college that you had to be full-time or no time. But fortunately,
full-time or no time.
Yeah.
Well, there's the choice.
Fortunately, I was able to get some political support, and we got that where I could actually. Well, what we were trying to do, and excuse me for backing up, but what we were trying to do was develop not just a residency program, but a fellowship program. And to have a fellowship program, you have to have enough patients for them to be able to be involved with,
right?
To be able to be certified, and to do that, we've manipulated through some political support and some support from the chairman of the Department of Surgery and Radiology at the medical college to allow me to be able to take on all the private hospitals in town as well. So we started early and finished most every day late.
Of course.
I averaged 14 cases a day for almost 40 years.
14 cases a day.
Yes,
You
ma'am.
were really going from like 6 a.m. until after 9, 10 o'clock.
Well, the only patient that I could tell that they were going to the what time we were going to start on their case was the first patient.
First one.
Yeah.
Yep.
But we had runners and used telephone to call patients and patients' family and explain to them if there was a delay and so on and so forth. So that, you know, if people are, if things are explained to patients, there's a lot more diminishing fear involved and anxiety. So, but I'm going to go back to Doddard for just a second.
Right. And Doddard being the one that actually brought the interventional.
Yeah, he's the one that started forcing the companies to understand what we had to have to be able to actually really treat the peripheral vascular disease, especially the advanced disease,
right,
to any degree. But Doddard had a patient that again, this was before the one we talked about earlier. He had a patient that had a significant stenosis. It wasn't totally occluded, but a significant stenosis, again in an iliac. And Fogarty was the
Dr. Fogarty, yeah.
Dr. Fogarty was the chairman of surgery at Oregon at that time. And so Doddard went to him, and he had the Fogarty balloon that the surgeons were using to extract clot. And so Doddard went to him, and he told him, he said, "I need you to make me one of your balloons, but I need to have it the size." He had measured the iliac. I needed to have that size. He said, "I want to prove a point." He said, "I want to prove that by using pressure, you can decrease the lumen size. I mean, the obstruction in the lumen and increase the lumen size." So Fogarty did. And so, you know, it was a compliant balloon, which means that it didn't have much force behind it at all. So, but anyway, he went down and Fogarty came down there and worked with him. And sure enough, you know, it worked like we'd all expected to on today's market. But it was short-lived, obviously. But the point was, he proved that something needed to be done. And he started off then with the dilators because that was the only, and Bill Cook made those for him. So,
and there's Cook Medical.
Yeah, and there's Cook Medical.
Was it? I mean, to be a part of the evolution from the very beginning of interventional radiology and the treatment for peripheral vascular disease, to be at the forefront and to literally have had nothing in front of you to do these things, and then to over time be a part of the evolution and development of these tools. There had to have been a lot of those catalyst moments along the way where you said, "Gosh, I wish I had this," and then there it came, and then "I wish I had this," and then it came.
Right. Well, you know, Dr. Doddard and I were good friends, and so was Kurt Amblatz. But he I think basically had the same philosophy that I've always had. And that's no, don't, can't, won't. Those aren't words that we understood. So, you know, you just got to keep
that. I love that.
You just have to keep pushing the envelope to make people realize that you've got to have this. And then if they don't really realize that, then you want to try to come up with an idea that might help them understand that they can make this and make it do this, or make this happen as far as the treatment's concerned. So, you know, I got involved in helping companies do things. You know, there's always either a need that's not met, or there's a device that all devices you want to try to make them as user-friendly as possible.
Right.
And as simple as possible.
Yes.
And so many people have a problem with that. And so that my involvement with the companies was to try to make them understand how to do that and help them redesign to make things both more user-friendly and more comfortable for the patient.
Now, I know you were inventing probably all along, you know, being someone who's at the forefront, a real pioneer in interventional radiology. You probably, you know, were inventing all the time, but I'm curious, At what point did you, make your foray into becoming an official inventor with the commercialization of a product? And we're going to get to that in just a moment, right here on the Heart of Innovation. Good cliffhanger. Stay with us. Don't go away. Hi, everyone, and welcome back to the Heart of Innovation. Dr. John Phillips is on assignment saving those piggies. I'm live with Dr. Rex Teeslink, interventional radiologist, inventor, and entrepreneur. My guest co-host, since Dr. Phillips isn't here, is Douglas Salisbury.
Yes, doctor. You were talking about that, and the big thing is, how do you see how the doctors themselves have changed with their thinking habits from where you started to where we are today, and trying new techniques, going below the knee or not being able to go below the knee, and how they try new things, and how many are willing to try the new things between the young doctors and the old doctors?
It's a good question.
Yeah, it is an excellent question. The real answer to the question to start with, as to why the surgeons and the cardiologists have gotten involved, is as I said, interventional cardiology started in 76. So once they came on board, of course, they were doing diagnostic and interventional coronary work. The reimbursement back then was significant for them. That got by Medicare kept cutting that, and they were looking for new income stream. And in difference to an interventional cardiologist, where everything has, interventional radiologist, where everything has to be referred to them, they, as well as the surgeons, had self-referral. So they could determine if the patient needed something done. They would get their training and come back and start doing the interventional work itself. As a result, on today's market, probably the numbers are close. The numbers are close that I'm going to give you, but roughly 70% of the interventional peripheral work being done today is done by cardiologists. Probably 25% with surgery, and 6 to 8% by interventional radiologists now, simply because there's no self-referring.
It must be frustrating for you being, at the forefront, being a pioneer in the space, and then having all of these other practices come in and not only infringe upon your territory, but literally take it, the carpet right from under you.
Well, yes, but I was fortunate enough that happened after. In my practice, I experienced a situation where no cardiologist or surgeons were involved, because they liked the service we gave, my philosophy was, the answer to the question is yes. Now, what's the question? And if you make yourself available and try to do a decent job, and especially take good care of the family and the patient themselves, but radiology is a specialty that does not lend itself to many people being willing to pay the price that it takes to do peripheral work, and the cardiologists and the surgeons are willing to pay that price, especially taking call.
And it's interesting because, back to another aspect of Douglas's question, a lot of these doctors say, whereas where your generation of doctor was all about learning, growing, taking it to a new level, new levels. It seems like what we find now are more and more doctors that argue for their own limitations and are afraid to actually push limits and take it to the next level. No, 2013 data says you can't treat below the knee, so we're just not going to treat below the knee. We're not going to find new ways to help this patient. Instead, we're just going to cut off the limb. Like, that's the answer. That's the best treatment, because 2013, we're now in 2024, data says that you can't do it. But an individual doctor is not trying to, that individual doctor is just resorting to amputation, versus they themselves looking to try and find new ways to innovate versus back when you were really coming up in the ranks? Every single doctor was all about innovating, not resting on their laurels, not giving up on the patient, really trying.
No, that's absolutely true. You know, the biggest problem we got today, well, first of all, technology is just going skyrocketing, going straight, well, almost straight up, but it's certainly going up in the right direction. But the total quality of medicine is not going in that same direction at that same speed. And the reason for that is that it was just presented at this meeting that 80% of the doctors in the country right now are owned by the hospital. So administrators are making decisions and not physicians like we were able to do when I was practicing. And I'm telling you, to take a new device and try to get into a hospital, you cannot believe the hoops you have to jump through and the time that it takes. Some of the administrations that we've dealt with will have a paper that was to be signed saying that it's okay for the hospital to buy this product, and it may stay there for weeks. We had one place where the docs wanted it from day one, and 9 months later we got it in the hospital.
Oh, that's so frustrating. Imagine all the patients that fell through the cracks that could have been helped along the way.
Well, and you see, you've got to have a spokesperson for your product in the hospital that's willing to buck or at least go head to head with the administration.
Right.
It's a totally different world now. It really is. And but I will say this: knowing what I know and knowing what was available when how the relationship was when I was practicing. If I didn't know any different and I'm starting as a freshman medical student, I'd still do the same thing. I'm willing to fight just a little bit, and I would still do the same thing. But
Doctor,
yes, sir.
So there's 2 million P.A.D. patients, but there's only 1,000 doctors. And is it that struggle of getting the patients to the right doctor? Like when we ask for second opinions, is the doctor says, no, I'm right, don't go to another opinion?
Well, if you have a doc that tells you don't, if you ask for a second opinion, you have a doc that tells you you don't need a second opinion, you need to get rid of that doc.
Good advice.
Yeah, that's the bottom line. A big problem that we do have too, as far as compliance is absolutely one of the biggest problems in medicine's always had and will probably always continue to have. But some of these patients that come in for a procedure, they have a transportation problem, and they have a problem getting to a facility to be able to get their medicine. There's a lot of factors involved that make it really, really difficult for some patients to get what they need. And then there's so many people that say you got a symptom going on and it gets to be a chronic symptom, and they say, well, it'll get better tomorrow. And any disease that the body that's inflicted on the body, the earlier your treatment, the better chance of a quality outcome. And that's so hard to make some people understand.
So what is the most frustrating part for you right now in medicine and continuing the evolution of the treatment for peripheral vascular disease?
Well, I would say industry is really working hard to do some unbelievable things. We've seen some really significant advances at the meeting this year versus last year, and certainly since we first met. Yeah. But the problem is how long it takes to get the FDA to approve them, how many patients have to be done in a study, the time and cost of all of that.
Oh, yeah.
Then once you get it in place, now you've got to fight the administrations to get it into the hospitals. And it's just frustrating. But my philosophy is P squared, patience and persistence. So.
What keeps you so passionate? Keeps you literally just pushing right now. At this conference, I actually got to meet his lovely bride for the very first time. That was really awesome. She is such a lovely woman, and she's
Thank
here.
you.
They're enjoying a little bit of New Orleans and the flair here. But what keeps you going? I mean, you could be off just enjoying the time, vacationing and enjoying just general retirement, but you keep persevering, you keep inventing.
Well, why do I want to stop as long as I'm enjoying doing what I do?
Yeah.
I get up every morning knowing that the glass is always half full, and as long as the good Lord is kind enough to me to allow me to function the way I've been able to function, maintain my mental faculties to a relatively decent level, I tell everybody, and I'm not trying to be a smart aleck when I do this, in all honesty, if I had the choice, which I know I don't, I'd like to retire the day I die.
Yeah, good for you. Well, we're very lucky to have you. I mean, be a part of this community, to see someone like you that just continues to push the envelope and inspire others to do the same. So we're going to hear what Dr. Teeslink is working on next right here on the Heart of Innovation. Stay with us. Don't go away. Hi, everyone, and welcome back to the Heart of Innovation. Dr. Phillips is off saving piggies. My co-host has been Douglas Salisbury, the chairman of the Global P.A.D. Association's patient task force. With us is interventional radiologist, retired, but current inventor, entrepreneur, longtime inventor and entrepreneur, Dr. Rex Teeslink, who's had such an impact on the treatment and evolution of the treatment of peripheral vascular disease. Dr. Teeslink, can we run through in the last few minutes here, some of the greatest milestones, some of the greatest inventions and impact that you've had, and what's your next step?
Well, it's almost embarrassing to talk about yourself,
but we love it.
But if you look at my CV, I was fortunate enough to have 5 firsts in the world. Either, I say in the world, they were either within the state of Georgia, they were regionally within the Southeast, they were nationally within the United States, or they were international.
Okay.
Obviously, when we got started, we had to use the X-ray equipment that the companies were making, and they were totally not capable of doing what we needed. Example being that when you start taking multiple films, you're putting a lot of heat into the tube, and it would shut the generators down because the generator was getting the information of the heat from the anode of the tube after the fact. So I kept trying to tell industry that, McNicholas was the tube manufacturer back then that had the majority of supplying tubes to actually to the world.
The catheters?
No, McNicholas X-ray tubes.
X-ray tubes.
Yeah. So I tried to tell them that they had to have a way of being able to measure that heat coming off that anode in order to do some of these things that we were trying to do. And CT was requiring the same thing. And they just didn't want to listen. So I got the hospital to buy what we called a glass package, and meaning that if a tube got blown, they'd have to replace it for the cost that was negotiated up front. So I started blowing tubes just to show them that you can't. They did not have a tube that would allow us to do what we needed to do.
Yeah.
So finally, after a rather significant cost to the company, they said, "Well, what are you talking about?" So I told them, and long story short, but every tube that's manufactured right now has a light sensor that sits next to the anode and measures the heat instantaneously. And of course, then that led to building tubes that were even better equipped to withstand the heat. But it was kind of interesting to do all that. Then the other thing is, when we started doing peripheral work, the tables that X-ray had, they moved 3 inches per second. But if you're going to get from the aorta to the feet with one bolus of contrast media and not have to keep putting contrast in there and potentially affecting the kidneys in a negative way, we started off by pulling the patient on a board. And of course, that wasn't too good from a radiation standpoint.
No.
And so anyway, long story short, I contacted an X-ray company into giving me a table, and my engineer in the hospital and I jury-rigged that and got it to step 14 inches a second, and now that's a standard in the world on every stepping table in the world. So all that was kind of fun.
Oh, I love
Wow.
it. And you know what he's talking about is, so when you pump in the contrast fluid and you're on the table, what they want to do, they need to move. There's only this square little X-ray thing, and they have to move the table as that contrast fluid is actually running all the way down from your aorta, all the way down to your toes. And so they have to move the table to keep up with it. And so he actually made it so that they could move that table a lot quicker to keep up with the contrast fluid.
Yeah, the image intensifiers now are 14 by 14, and so we wanted it to step 12 inches per second, so we'd have a two-inch overlap.
I love it. Well, Dr. Teeslink, thank you so much. We got to wrap up here. We're going to have you back. What's the name of your company in case people want to follow you?
Insight Vascular, and the product is a closure device called Site Seal that closes. We have no restriction. We're the only FDA cleared that has no restriction to sheath size. We can close multiple sheaths within a single vessel with one device and leave nothing behind. Patients get elevated 30 degrees headwise when they're taken off the table, and no restriction to leg movement.
See, that's great. I mean, most people who end up at the end of the procedure, you know, it's almost like you have to lay there flat, and yours actually allows you to come up just a little bit.
Then they can eat and they can drink.
Yep.
They don't have to work. The anesthesiologist doesn't have to worry about aspiration. And you can always breathe better standing up than you can lying down, because when you lie down, you breathe through your mouth, which is not as efficient as breathing through your nose.
No. Well, thank you so much, Dr. Rex Teeslink. He is an interventional radiologist, retired but not retired. He's a current inventor and entrepreneur. We really appreciate you being here with us, and we'd love to just keep up to date. And we'll probably have to have you back again to continue your story.
Well, thank you very much. I've really enjoyed it, and I appreciate the audience being willing to listen to a dinosaur.